Hi everyone. I want to talk to you today about diabetes mellitus, but I'll be specific about the treatment and insulin in particular. I could say that insulin could be tagged as a rescue agent. So the patient, go along with me, make sure you go through all the slides so that you can have the maximum benefit of this presentation. Thank you. Insulin, the brief history is that it was first called insulin in April of 1922 from the Latin word insula, and that means an island because it was secreted by the islet of Longacting. Thanks to Dr. Frederick Banting from Ontario, of course, a Canadian, who won Nobel Prize in 1923 for his work on the discovery of insulin. He was a surgeon and he worked along with his assistant named Charles Best. We are remembering them today. Many thanks to them and the pride to Canadians. Before then, diabetes mellitus with diabetic ketoacidosis was death sentence. There are many types of insulin, and I will take the time to take you through all of them. Human insulin is NPH or neutral protamine agonist, regular insulin, lispro, or glargine. It is worth noting that postprandial insulin secretion endogenously should be replicated by the exogenous insulin, but NPH and regular insulin couldn't meet that requirement. Therefore, in type 1 diabetes mellitus in particular, a more replicant ones were manufactured to be able to meet up with that requirement. And they are lispro, aspart, glycine, glargine, detamine, or deglude. Things to point out. Regular insulin is used for pre-meal, but analogs like lispro, aspart, glutathione do act faster and shorter in terms of duration of action, and that is making them more suitable for pre-meal than regular. So in other words, you can use regular for pre-meal, but we have better ones that will be able to serve that purpose, like lispro, aspart, and glutathione, because they work faster and they have shorter duration of action. So when the patient has gotten the meal ready to eat and you want to give the shot, you go for one of those three. Regular is not that it's bad, but when you have something better, you do away with good. In the same vein, NPH for basal coverage is less preferred for the basal purpose because the analogs like glargine, detamine, or deglude are more suitable. Why? They have longer hours of action and they have longer plateau. So when they are injected, you don't need to bother about fluctuation of your blood glucose because when it peaks, it's going to be there for a long period of action time. NPH peaks few hours after administration and drops gradually over the day. Glargine have a long plateau, which means effect on glucose control is almost at the same rate for the entire day. And the effect will start 1 hour or at most 1 to 2 hours after injection. Imagine that. That is Lantus. So when you have that, then you tend to use that and use less of the same other insulin that could serve as beta insulin coverage. Let me quickly open your eyes to know why you are on a particular type of insulin. There are those ones we call rapid acting because the onset of action is between 3 to 15 minutes. They peak within 40 minutes to 70 minutes, about 1 hour plus, and they remain, duration of action for almost 2 to 4 hours. In that group is Humalog, the Lispro, Novorapid, the Aspart, Apidra, the glycine. The regular insulin is called the short-acting insulin, and we have two examples there, Humulin R or Novolin Toronto. Insulin is Canadian in origin, and now people are moving up to get insulin. The onset of action of regular or short-acting insulin is the first 30 minutes, and it's going to peak within 2 to 4 hours, and the duration of action will last for up to 8 hours. The intermediate acting, which could be used as beza, the first one in that group is neutral protamine lispro, and it's also called Humulin N. The onset of action is within the first 2 hours, peaks at 6 hours, and the duration of action will last for almost 15 hours. NPH or Novolin NPH will also have the same type of onset of action of 2 hours, peaks within the same range between 4 to 12 hours, and the duration of action is between 12 to 16 hours. So they are not far apart in onset of action, peak, and duration of action. The two intermediate acting ones, Humulin N and Novolin NPH. The long-acting insulin, the one that most of us will prescribe or use is glargine or Lantus. But let me go over the remaining two. Insulin, degludec or Tresiba. We have onset of action at 2 hours, peak is not known, and it's going to work for greater than 4 hours. So once it's, the onset of action starts in, it starts working, it's going to go just like that at that same level. Insulin detamine or Levamine, the onset is also within 2 hours. It's going to peak within 3 to 9 hours. And the duration of action is 6 to 24 hours. So less than that of Degludec. How about Lantus, the popular one, the glargine? Also, the onset is first 2 hours, no peak, because once the onset is there, then it continues just like that. And duration of action will last 20 to 40 hours. So the whole day, you're fine. Just do your glucometer, glucose check. Beta, intermediate NPH or NPL or long acting. You may use short acting or rapid acting, short acting regular insulin, Humulin R, or the rapid acting like Lispro, Humalog, but then it has to be continuous infusion or by insulin pump. and how many people will be ready for that stress. So for basal, we don't use that except for those that are using insulin pump. For intermediate, we use NPH or NPL. For bolus, short acting or rapid acting could be given before meals to handle glucose surge after eating or postprandial. Like I said earlier, most people would prefer to use rapid acting for that purpose. Pre-mixed insulins are also available, but they are not getting out of favor, not being prescribed frequently anymore. But then we need to, whether nursing students or medical students, we need to know that they exist. Like regular, when you hear the word premixed insulins, just think of two types of insulins here. It's either the regular insulin and one intermediate, or one intermediate and rapid acting insulin. So like regular 50% of the content and NPH 50%, or Lispro Humalog 25 and NPL 75, or Humulin R 30 and NPH 70, or Novolin Toronto 30 and NPH 70. You don't mix insulin glargine, that is Lantus, or insulin glutamate levemir with any other insulin. No, don't mix them. Use immediately if NPH is mixed with regular. NPH with rapid acting like Lispro or Aspart is fine, but must be taken within 15 minutes before meal. Okay? Afrezza is an inhaled insulin. It is like the subcutaneous insulin Lispro. So it's very good. And we'll talk about that in a bit. We give insulin subcutaneous because absorption through that means is variable. And insulin depot is formed subcutaneously. And that is what you need. You don't need something that will push into the circulatory system very fast and then crash the glucose level. And the patient would then die of hypoglycemia. There's high pressure jet injectors. No needle is used, but it is more rapid glucose lowering kind of a device. It's too, no, it's not good. It's not what we will be running after to get and give everybody. Now, pen injectors with Prevail cartridges. I will show a picture very soon of that. That is gaining favor right now. By the time I show the picture, it will be clear. Insulin pump. Yes, you administer rapid acting insulin for that purpose, and subcutaneous catheter will be needed. It will be programmed to deliver bolus insulin at meals and continuous basal dose. The advantage is that it's very flexible, it improves quality of life, but the disadvantage is it can be disconnected inadvertently. In other words, it can be disconnected without the knowledge of the patient, and you know what the implication will be. Yes, this is the insulin pen for the purpose of trying to avoid copyright infringement and all this stuff. I've decided to use my hand to draw this. So you can see the needle, and you see the needle attachment point okay, and the insulin reservoir, and there will be an aperture here where you can see the amount of insulin when you adjust with the adjustment dial. So the insulin cartridge will be attached, and then you adjust your insulin level as the amount you want to give the patient. Then when that is ready, you remove the needle cap and you just inject, using this button, injection button. So that is insulin pen. It makes life easier for nurses and I think for patients as well. Mistakes, errors, giving excess insulin is reducing, with the availability of this insulin pen. So it's a new dimension in diabetes mellitus treatment and many appreciation to the manufacturers. It's very good, very good. And that's why I took the time to draw it out so that we'll know the mechanism and know the advantage of it. Where can we inject insulin in our patient or in ourselves? The abdomen is the best region. You can use the thigh, the upper part of the thigh, you can use the arm. Don't exercise immediately after injection, particularly if it is the thigh region, because that could lead to fast absorption. And if there's fast absorption, you know what that will lead to? There'll be a quick and sudden drop in blood glucose, which is hypoglycemia. And when the brain is not supplied with glucose within some few minutes, 5 to 10 minutes, there could be trouble. Then it is good to rotate the injection sites. By the time we get to complication of insulin, we will see something called dystrophies and so on and so forth. By the time we get there, I'll tell you more. That's why when you rotate the injection site, it will prevent that. You pinch for subcutaneous injection and you insert at angle of 45 degrees. That'll be better. You may experience mild allergic reaction if you are new to it, in particular, like itching, pain, redness, or swelling at the site of injection. There are regimen. Insulin regimen, your doctor will calculate between 0.5 to 0.7 units per kilogram, and 40% of whatever the amount is, just do the calculation, 40% of that will be given as basal insulin at bedtime. Now, there will be 60% left, right? We'll divide that into 3. So 20, 20, 20. The first 20, the amount that whatever it is in units, international unit, will be given bolus at breakfast. The second one will be given bolus at lunch, and the third one at supper time. If it is premixed, 2/3 of the total dosage meant will be administered before breakfast and 1/3 before supper. But remember, I told you premixed is not gaining ground anymore. But to those who are still using it in other parts of the world, 2/3 of the total amount meant to be taken by that patient per day for that day, 2/3 of it should be given in the morning before breakfast, and 1/3 before supper time. Yeah, in type 2 diabetes mellitus, only basal insulin will be given as 10 units at bedtime. You can increase by 1 unit until you achieve the desired goal of glucose less than 7.0 millimoles per liter. Adjust as necessary. If sugar is high in the morning, you need to use higher dose of beta at bedtime. But if the sugar level is high at lunch, then you adjust your breakfast bolus to be higher. If sugar is very high at supper time, you need to increase the dose of lunch bolus or increase that of the basal insulin in the morning. Increase bedtime sugar, then you increase supper bolus. So you need to make that adjustment so as to balance up.